special thank you to Dr. Gage, who is joining us today from Cleveland Clinic. Dr. Gage is an interventional intensivist. How unique is that? She's in cardiology, interventional cardiology, and critical care. I couldn't really think of a better or more qualified person to talk to us about our roles as cardiologists in the intensive care, especially during this very challenging time. Thank you so much for taking the time to talk to us today, Dr. Gage. And hopefully we can see you in Houston very soon.
Yes, well, hi everybody. Hello from Cleveland. Thank you so much for this opportunity. I have never done a Zoom conference before. I've obviously participated in quite a few recently, but so I hope that this goes smoothly. Thanks for having me. So let's see how I can make this go. All right, so I didn't know what you guys looked like, and normally I would take the opportunity to say hello. It's a little awkward to not meet you guys in person. This is the photo that's on your website, so I don't know if it's up to date. That's you, Nadeen, right? Is this you?
It looks like her.
It's a little fuzzy.
Me.
You guys need closer up pictures on your website. But so you look like a very smart group. So I tried to step up my game here, but here we go.
There's always Photoshop, and so.
Yes, that's exactly right. Okay, now I have to get this off of my, okay, let me figure out how to move my Zoom. Okay, so I was asked to talk about mechanical ventilation and pressors today. These are huge topics, so I hope that this serves as a practical refresher. Please feel free to interrupt me at any time. I'm happy to answer any questions that you may have. Shown here are the common cardiac intensive care therapies at 16 large cardiac ICUs in recent years. The two topics for today are well represented in our cardiac ICUs. About 20% of patients in our CCUs receive mechanical ventilation, and pressors and inotropes are present in almost 40% of these patients. So hopefully these will be high yield topics. I'm going to start with the basics of mechanical ventilation. We need to start by diving into some of the specifics of, or before we dive into the specifics of mechanical ventilation, we have to redefine some basic terms related to pulmonary physiology. For the general fellows here, these are terms you're probably familiar with from your days in the MICU. And if there's anyone who hasn't been in an internal medicine residency in a while, these may take you back a few years. We're going to talk a lot about PEEP today. PEEP is positive index expiratory pressure. This is the pressure above atmospheric pressure that is maintained throughout the respiratory cycle. PEEP functions ultimately to prevent alveolar collapse. The next definition is that of the mean airway pressure. So mean airway pressure is the average pressure throughout the airways of the lungs over the entire respiratory cycle. The plateau pressure is the pressure that is seen by the alveoli. So this is the maximal pressure seen in the alveoli, and it's measured at the end of an inspiratory pause. So basically what this is it's analogous to if you were to take a deep breath in and then just pause your breathing. The stagnant pressure that's seen in the alveoli at the end of your inspiration is the plateau pressure in the lung. The next definition that we have to go over is compliance. So compliance is basically the distensibility of the lung. It's defined as the change in volume for a given change in pressure. The larger the volume change for a given pressure, the more compliant the lung is. It essentially is the elasticity of the lung. And lastly, this is pretty self-explanatory, but FiO2 is the fraction of inspired oxygen. When talking about mechanical ventilation, the FiO2 is the concentration of the oxygen administered by the machine. So you are the one who gets to set this value. It usually ranges between 0.21, which is the usual fraction of inspired air, to 1.0, which would be 100% oxygen delivered with each breath. So let's begin with a discussion of why we employ mechanical ventilation. There are three main reasons why we may choose mechanical ventilation. These are oxygenation, ventilation, and safety. Obviously, if a patient is hypoxemic or hypercarbic, i.e. they're failing to oxygenate or ventilate, we have to do something. Usually that involves mechanical ventilation. Patient safety is a third reason that I would consider mechanical ventilation. In patients with altered mental status, for example, airway protection with mechanical ventilation becomes a standard of care. In my life as an interventional cardiologist, I sometimes find myself in a situation where I have to intubate a patient in the cath lab in order to safely complete my procedure. And this is certainly an okay goal for the initiation of mechanical ventilation. So once a patient is placed on mechanical ventilation, we need to focus on their oxygenation and their ventilation. It's possible to optimize oxygenation in multiple ways. The most common ways of optimizing oxygenation are by increasing the fraction of inspired air, by increasing the mean airway pressure, or by decreasing the systemic consumption of oxygen. At the bedside, the simplest way to improve oxygen is just to increase the fraction of inspired oxygen. You do this simply normally by just turning a knob. You can also increase the mean airway pressure. This recruits more alveoli and increases the surface area that's available for oxygen exchange. This is usually accomplished by increasing the PEEP or by increasing the inspiratory time relative to the expiratory time. This ultimately increases alveolar recruitment and the surface area that's available for oxygen exchange. Conversely, it's possible to increase oxygenation by just decreasing peripheral oxygen consumption. This is achieved by sedating the patient, administering increasing amounts of analgesia, or you can just paralyze the patient, which significantly decreases their oxygen demand. As far as ventilation, ventilation is how we deal with the CO2 concentration in the lung. It's governed by this equation. So minute ventilation is equal to the respiratory rate times the tidal volume. On the ventilator, you set the respiratory rate directly, and then depending on the mode, you can set the tidal volume directly or indirectly. We'll talk more about this in detail, but keep this in mind as the equation for how you can optimize ventilation. So modes of mechanical ventilation. There are many ways of classifying ventilator modes. My goal in today's discussion is to highlight the two most common forms of ventilator modes. And with the basic knowledge of these two modes, I think that you can ensure effective and safe ventilation for your patient. We're going to focus mainly on assist control ventilation and also briefly discuss synchronized intermittent mandatory ventilation, which you're probably familiar with as SIMV. So assist control is likely the most common ventilation mode you will see in the MICU or in the cardiac ICU. In assist control ventilation, the physician sets the ventilator to deliver a specified volume, specifically the tidal volume, or a specific pressure. The ventilator then delivers this pre-specified volume or pressure for all breaths. The same volume or pressure is delivered with each breath, regardless of whether the patient or the machine initiates the breath. These modes are called volume control, pressure control, or you may also see them referred to as VC CMV or PC CMV. This is in distinction to SIMV, where, similar to assist control, the physician sets the ventilator to deliver a pre-specified volume or pressure. The ventilator then delivers this pre-specified volume or pressure only for a set respiratory rate. The patient can take spontaneous breaths between mandatory breaths, and the ventilator does not deliver this pre-specified volume or pressure for any breaths that occur above the set respiratory rate. So if we look at this, this is a representative example of what the pressure waveform looks like for volume control. Multiple screens up here. So on the x-axis here, you can see you have time, whereas on the y-axis you have pressure. We aren't going to study this in detail, but what you should see is that every breath that is administered looks almost exactly the same. This is typical for most assist control modes of ventilation. In the waveform tracings that you see here, the first three breaths are triggered by the machine, whereas the third breath or the fourth breath is triggered by the patient. You can see this here because there's a slight negative deflection. Are you guys able to see my cursor? Okay, so there's a slight deflection from the baseline. This is what you see when the patient begins inspiration by making some degree of effort. There's a negative deflection in the baseline. What this means ideally here, or what this I want you to show with this, is that the first three breaths don't have this deflection. They're initiated by the ventilator. Here, the fourth breath the patient's initiating this breath. However, because this is assist control, in assist control, the machine gives the same breath every single time, okay? Assist control ventilation is the mode of choice in most circumstances. It allows the ventilator to take over the work of breathing and is preferred when a patient has acute cardiac or respiratory failure. It provides full respiratory support. Ultimately, the pros of assist control breathing are that it's full support and that the clinician can tightly control the tidal volume or the inspiratory pressure that the patient gets. However, there are some cons. As we just saw in the waveforms, if a patient is breathing above the set rate, he or she gets the full tidal volume on every breath. So in a tachypnic patient getting this tidal volume every single time they breathe, they may ultimately develop a respiratory alkalosis, or they could air trap. So this is especially problematic in patients who have COPD or asthma. So here is a representative sample of what the pressure waveform looks like for synchronized intermittent mandatory ventilation, or SIMV. Again, on the x-axis we have time, and on the y-axis we have pressure. What you can see here is that these ventilator breaths are not the same. And this is the difference between SIMV and assist control. In SIMV, the predefined volume or pressure is given only for a set respiratory rate. The patient then can take as many spontaneous breaths as he or she would like above the respiratory rate. If you breathe above the respiratory rate, you get these smaller breaths. So either the patient breathes entirely on their own, or sometimes on the bottom here, you see that we give a little bit of pressure support to help the patient breathe on their spontaneous breaths. But ultimately, these are not the full tidal volume or pressure volume that you would get in assist control. Does that make sense to people? Okay. So SIMV is also a very popular mode of mechanical ventilation. In my experience, this is more frequently used in surgical ICUs and those ICUs that are run by anesthesia. The pros of SIMV are that it too takes over the full work of breathing for the patient, similar to assist control. However, it allows for more spontaneous breathing, and although the data isn't great, it's thought that it may be a helpful mode for weaning of mechanical ventilation, since it does allow the patient to have increased spontaneous breathing. The cons for SIMV are largely related to patient fatigue. If the respiratory rate is set too low, then the patient may become fatigued due to his or her excess work of breathing. Additionally, if the support that's provided on those patient-initiated breaths is too low, the patient also may become fatigued. So ultimately, in most ICUs, you will use assist control as the default mode for ventilation. I think that in almost all cardiac ICUs, unless they're run by anesthesia, you'll see assist control be the predominant mode of ventilation. Whether you use pressure control or volume control, again, they're both forms of assist control, is largely due to local practice. So in most patients, pressure control is more comfortable and may be better tolerated. So at the Cleveland Clinic, for example, our default mode is that all of our patients get put in pressure control across almost all of our cardiac ICUs. However, volume control remains a frequently used mode, and it's advantageous in certain circumstances that I'm going to come back to later. So now that we've encountered or discussed the most common ventilator modes, we need to actually talk about how you choose your ventilator settings. And as I mentioned earlier, the goals of mechanical ventilation are oxygenation and ventilation. So when we're picking our initial ventilator settings, we need to choose settings that support safe and effective oxygenation, as well as ventilation. Furthermore, mechanical ventilation should avoid injury to the lung, right? We do not want to be harmful here. So this means that we want to avoid ventilator-induced lung injury, which now I have to define for you guys. So ventilator-induced lung injury is most commonly caused by one of the three mechanisms that's seen here. So volutrauma is caused by overdistension of normal alveolar units. You have to be especially mindful of this when you're ventilating lungs with regional disease, like in our ARDS patients. In these patients, there's a risk of volume preferentially going to healthy lung and damaging the functional portion of the lungs. Barotrauma is caused by high pressure injury to the lung. And then atelectrauma is lung injury that is caused by repetitive collapse and reopening of the alveoli. This repetitive opening and closing causes shear stress, which has a damaging effect on the alveoli. So again, we want to avoid these types of injury so that we don't have harmful mechanical ventilation. The initial ventilator settings that you get to pick in most modes are seen here. So these include the mode, which we just talked about, the FiO2, the respiratory rate, tidal volume, and the positive end expiratory pressure. So we've already talked about mode quite a bit. Ultimately, this is the first thing you will select when you turn on the ventilator. In most situations, I think, again, this will be assist control, and then just based on your local practice, you'll choose whether or not this is pressure or volume control. The second thing that you pick is the FiO2, or the inspired fraction of oxygen. At first, whenever we intubate someone, we choose an FiO2 of 1, which is 100%. When you come back to the bedside, so normally within 30 minutes to an hour, you look at the SpO2. If the SpO2 is greater than or equal to 88%, the recommendation is that you just make a big move and you bring the FiO2 down to 60%, or 0.6 is what it'll say on the ventilator. The respiratory rate is something that in all modes you'll dial in a rate. And so this will serve at least as your backup rate for the patient. Usually you set a rate of 14 to 18 breaths per minute, but this really can be variable depending on exactly what the patient looked like the moment before they were intubated. If they're really sick, their respiratory rate may be very high. And I think that my recommendation here is that in general, the respiratory rate that you pick initially should approximate the patient's pre-intubation respiratory rate. This doesn't mean that you leave them on this setting for a long time, but that when your first 30 minutes, approximate what they were doing before you intubated them. So there are some additional ventilator settings. And again, these that we're choosing are guided by our desire to avoid ventilator-induced lung injury. We've picked the mode, we've picked the FiO2, and we've picked the respiratory rate. So the next thing that people will need to pick is the tidal volume. If you're in a volume control mode, you set this tidal volume directly on the ventilator. If you're in a pressure control mode, where the operator chooses the pressure to be given by the ventilator, the goal is to pick a pressure that, for that patient's given lung compliance, allows you to achieve your target tidal volume. So you need to somehow know what this magic tidal volume number is. And we know from this study here, in the New England Journal in 2000, this was a landmark trial that looked at tidal volumes of 6 to 8 cc's per kilogram, compared to traditionally patients were ventilated with 10 to 15 cc's per kilogram tidal volumes. And that this trial resulted in lower mortality in patients when they were ventilated at the lower tidal volumes, so 6 to 8 cc's per kilogram. And this trial was actually stopped early due to mortality benefits seen in the low tidal volume group. So for this reason, the recommendation is that you choose a tidal volume that's equal to 6 to 8 cc's per kilogram for the patient's ideal body weight. Ideal body weight is something lots of our patients fail to achieve, but it's easily determined if you know the patient's height. So this avoids volume trauma, which again is that lung over distension. And this is, you're picking 6 to 8 cc's. How do you know what the ideal body weight is? Well, it's really important when the patient comes in that the nurses grab a accurate height. Most of our EMRs will have a height kind of with the patient demographics, but lots of ICUs you may not notice have yardsticks actually lying around. And the yardsticks are there because the whole tidal volume is predicated on the patient's height. So this is from the ARDSnet information. You divide it by male and female and then take their height, and it tells you what their ideal body weight is. You then multiply this by 6 to 8 to get their tidal volume. The next setting that we need to pick on the ventilator is then the PEEP. Earlier, we defined PEEP as the pressure above atmospheric pressure that's maintained throughout the respiratory cycle to prevent alveolar collapse. So PEEP here directly supports our desire to avoid lung injury due to that repetitive opening and closing of the alveoli. In most of our cardiac patients, our usual initial PEEP is 5 to 10 centimeters of water. Again, this is something that you just dial in on the ventilator. Once we have chosen these initial settings, we have to make sure that we don't have ventilator-induced lung injury. So again, it's extremely important to prevent barotrauma, which is the pressure injury to the alveoli. And preventing barotrauma requires that the plateau pressure of the lung is maintained at or below 30 centimeters of water. So what is this? Well, the equation that you see here is the equation for transpulmonary pressure. Transpulmonary pressure is the pressure that drives the alveolar stretch in barotrauma. So it's the pressure that exists across the alveoli, hence the name transpulmonary pressure. So the plateau pressure, as we talked about, is this alveolar pressure at the end of an inspiratory pause. It's the maximal pressure seen in the alveoli that's measured when there is no flow. The pleural pressure is really difficult to measure. This is the pressure between the parietal and visceral pleura of the lung, and it's usually negligible. It's just slightly negative, but we can say that it's negligible. Pathology of the chest wall or in the abdomen may make this an untrue statement, but in most patients, we just assume that the pleural pressure is 0. That means that the transpulmonary pressure then is equal to the plateau pressure. And ultimately, plateau pressure is usually used as a surrogate for transpulmonary pressure. So we keep a plateau pressure of less than 30 centimeters of water. And all that this really means is that tiny little alveoli, that the difference between the inside of it and the outside of it, there is no more than 30 centimeters of water pressure gradient across that alveoli. If there is more than 30 centimeters, that alveoli is at risk for barotrauma and ventilator-induced lung injury. So what are the practical aspects of measuring the plateau pressure? This is actually something that we can do. So we just established that this is a surrogate for transpulmonary pressure, that it's used to measure alveolar stretch, and that it should be less than 30 centimeters of water. So for a patient on a ventilator, there's actually just a button that says inspiratory pause. And all that you have to do is push this button, and you will get a waveform that looks like this. So as the patient inspires, you do an inspiratory hold with your magic little button, and you get this pressure. This pressure here is the plateau pressure, and this should just be less than 30 centimeters of water. So we've now picked all of our initial ventilator settings such that you've decreased the risk for ventilator-induced lung injury. To recap, you're avoiding volutrauma by picking a tidal volume of 6 to 8 cc's per kilogram of ideal body weight. You are avoiding barotrauma by having a plateau pressure of less than 30 centimeters of water, and you've chosen a PEEP of 5 to centimeters to prevent atelectasis trauma. Now, I think I've made it 33 slides, I counted, without using the word COVID. So I think that that's probably a record for any presentation given in the spring of 2020. But here we go, COVID. So how did we get here, and why are so many subspecialists suddenly being lectured on mechanical ventilation? Obviously, the topic of the moment is COVID-19, and this has brought respiratory failure to the forefront. So with many physicians being asked to refamiliarize themselves with ventilator management, obviously we end up with lectures like this. The data from China suggests that respiratory findings are very common in our COVID-19 patients. Pneumonia in the Wuhan series was present in 91% of their COVID-19 patients. And 6% of those patients in Wuhan required mechanical ventilation. Another 3.4% went on to develop acute respiratory distress syndrome. So the incidence has been even higher in the Italian series, with up to 10% of infected patients in Lombardy developing ARDS. Based upon this and what's been reported in various places within the United States, the concern is obviously that many American physicians will be called upon to manage mechanical ventilation in the setting of hypoxemic respiratory failure and acute respiratory distress syndrome. So I wanted to take a sidestep and talk about ARDS for just a moment. One of the main reasons, or one of the common things that we see in our MICUs as an indication for mechanical ventilation is ARDS. And ARDS is one of the main pathologies that we're seeing in COVID-19. So I think that it's important in our routine practice as well as in the COVID population. So acute respiratory distress syndrome, or ARDS, is a life-threatening form of injury. This lung injury can be the result of a primary parenchymal lung injury such as pneumonia or aspiration, or it can be from a systemic process such as trauma or sepsis. Increased capillary permeability is the hallmark of ARDS. This leads to inflammation as the inciting factor. So ultimately what happens is you get damage to the capillary endothelium and the alveolar epithelium. This results in protein accumulation within the alveoli. Once you get protein within the alveoli, you get activation of pro-inflammatory cytokines, and then you get pulmonary fibrosis. This cascade ultimately leads to loss of functional lung tissue, and as ARDS progresses, you get fibrotic, stiff lungs with low compliance. Hypoxemia then ensues, and patients ultimately progress to ventilator dependence. So in practice, ARDS is defined by the Berlin definition. This requires that patients have acute onset of some form of lung injury. They then develop bilateral opacities on chest x-ray. And one of the criteria is that these bilateral opacities are not thought to result from left-sided heart failure. So the Berlin definition of ARDS stratifies the severity of lung injury using a ratio of the partial pressure of oxygen to the fraction of inhaled oxygen. So PaO2 to FiO2, which we refer to as the P to F ratio. By definition, ARDS is when you have a PaO2 to an FiO2 ratio of less than 300. The mild ARDS is when your P to F ratio is between 2 and 300. Moderate ARDS is when your P to F ratio is 100 to 200. And then severe ARDS is any time when the P to F ratio is less than 100. So in our patients with ARDS, a lung protective ventilation strategy similar to that we just described is employed to avoid ventilator-induced lung injury. In March of this year, the Surviving Sepsis campaign issued guidelines on the management of critically ill patients with COVID-19. In these guidelines, it was recommended that COVID-19 patients be treated as typical ARDS patients. I think that this means that for COVID reasons, we should familiarize ourselves with ARDS management. Also, you will see ARDS certainly in the cardiac ICU, so this is something to be familiar with. ARDS are managed patients exactly as I already described, but some of the goals of their ventilation are different. In these patients, we do the same things. We begin with low tidal volume ventilation, 6 to 8 cc's per kilogram, and then we want a low plateau pressure of less than 30 centimeters of water. However, in these patients, we also allow permissive hypercapnia. This means we are willing to tolerate a pH as low as 7.2. This makes sense. Our main goal in these patients is to avoid lung overdistension and elevated alveolar pressures. So we do this by lowering our tidal volumes. However, as we looked at earlier, your minute ventilation is your respiratory rate times your tidal volume. So when you decrease your tidal volume, your minute ventilation goes down and your CO2 increases. This makes you more acidotic. Okay, so in order to protect the lungs with low tidal volumes, we allow permissive hypercapnia. We also then allow relative hypoxemia. So this means that in our patients who have ARDS, we are willing to tolerate a PaO2 of 60 to 80 or an SpO2 of 88 to 94%. Ultimately, we want an FiO2 below 60 if we can get it there, and we're willing to do that by allowing the patient to be relatively hypoxemic. One caveat just to keep in mind is that even though the Surviving Sepsis campaign told us that we should manage these patients, the COVID patients, as ARDS patients. In ARDS, we say SpO2s of 88 to 94% are acceptable, but the COVID specific guidelines were that we wanted an SpO2 of 92 to 96%. I think that ultimately the goal here is that you want a SpO2 in the low 90s, that's perfectly acceptable for patients with ARDS or for COVID. The first two things here are things that we've talked about, but in order to really ensure that you're not having high tidal volumes in these patients, the recommendation for ARDS patients and for our COVID patients is that we start with volume control. So this is assist control ventilation, but volume control. That means that we've picked a pre-specified tidal volume and that the patient on every single breath, regardless of whether it's initiated by the patient or the ventilator, they're going to get a pre-specified tidal volume. So I just want to walk through how this looks. So your patient has ARDS or they have COVID. You pick volume control. This is a form of assist control. You then we're going to go through this. Tidal volume, as we said, 6 to 8 cc's. We want the lowest tidal volume that we can get, so we're going to start with 6 cc's per kilogram. Again, you use this chart from the ideal body weight chart. Then the respiratory rate. In patients who are in extremis, their respiratory rate is probably higher. You're also then going to be setting low tidal volumes. In order to compensate for that low tidal volume, you very well may need a higher respiratory rate. So in patients who have ARDS or COVID, you're probably going to be closer to the 20 breaths per minute than on the low side of this spectrum. And again, I think one of the reasonable things to do is to approximate their respiratory rate from before you intubated them. Again, FiO2 start with 100%. PEEP initially start about 8% in most ARDS patients. You ultimately may need very significantly increased PEEP in these patients. So we've set our initial parameters for our ventilator. Then we have to figure out, did we do this right? And if not, what the heck are we going to do? So you have to reassess the physiological response to your initial ventilator settings. And the way that we do this is by almost always even if there's not an A-line, you're going to obtain an ABG 30 to 60 minutes after initial stabilization. And then we're going to work within the confines of permissive hypercapnia, permissive hypoxemia, and then wanting the goal of a low plateau pressure. So this is one of my favorite quotes for talking about ventilator titration in ARDS. Dr. Mireles is our MICU director here at the Cleveland Clinic, and he was my critical care program director. Ultimately, he says, a pH of 7.35 is not a success, it is an opportunity. And I think that we have to get in the mindset of knowing the indication for why we intubated someone. If we intubated a patient, even one of our cardiac patients, not a COVID patient, but we are concerned that they have ARDS, we want to give them the lowest tidal volumes possible, which means we're going to need to allow them to be acidotic. So you do not want to titrate your settings to achieve normal pH. You want to get as close to a pH of 7.2 or 7.25 as possible, so long as the patient can tolerate that. So here's what you do in order to titrate. It's been 30 to 60 minutes since the patient went on the ventilator. The pH, if your pH isn't near 7.2 or 7.25, you're going to lower the respiratory rate so that you're going to try and target a lower pH. The FiO2, you decrease this again to meet your SpO2 targets. If this is a typical ARDS patient, 88 to 94%. If it's a COVID patient, 92 to 96%. Then the plateau pressure. So we talked a lot about what the plateau pressure is, but what if it's above 30? So if your plateau pressure is above 30 and your pH is still higher than where you need it to be, then decrease your tidal volume. This will make the patient more acidotic. It also delivers less volume, and so the plateau pressure should decrease in a corresponding fashion. If the plateau pressure is greater than 30, but you don't have any room on your pH, then you're going to very slowly decrease your PEEP. This decreases the plateau pressure. It also will decrease your oxygenation, so you just need to be mindful of that. So The last thing that we need to monitor in our patients as we're coming down on their FiO2 or going up on their FiO2 is their PEEP. And PEEP is actually something that's pre-specified for you. So if the patient has ARDS or COVID, then you are going to just use this table. This is from the ARDSnet group. There's a lower PEEP table and a higher PEEP table, depending on how sick the patient is. But this tells you that for any given particular FiO2, what PEEP you should be administering. Let's move on to, given that we're all cardiologists, we shouldn't have a mechanical ventilation lecture without mentioning the hemodynamic effects of mechanical ventilation, because ultimately the lungs are fine, but the heart's really just that much better. So let's talk about the hemodynamics of mechanical ventilation. So we should first start with a discussion of how spontaneous respiration affects hemodynamics, and then we can compare this to the interaction of mechanical ventilation in hemodynamics. So the fundamental difference of spontaneous respiration is that it's driven by the generation of negative pressure due to contraction of the diaphragm and the intercostal muscles, whereas positive pressure is literally driven by a machine forcing positive pressure into the pleural system. So what do I mean? Well, hemodynamics and respiratory mechanics are profoundly affected by the pressures in the pleural space. This pressure is known as the pleural pressure, the intrapleural pressure, or the intrathoracic pressure. And this is just the pressure that you see here in between the visceral and the parietal pleura. These terms are all interchangeable. Ultimately, this is the pressure that exists within the pleural space, and it's going to be at rest in a spontaneously breathing patient slightly negative. This is because there are two opposing forces at rest: the thoracic wall, which wants to spring outward, and the alveolar units, which have a tendency to collapse. The resting equilibrium in a normal spontaneously breathing patient is a very slight negative intrapleural pressure or intrathoracic pressure. So during spontaneous inspiration, the diaphragm and the intercostal muscles contract. You have a negative pressure. When this is an active process, and during expiration, this is just driven by chest wall recoil, and expiration is a passive process. So when a patient is mechanically ventilated, either through non-invasive means such as CPAP or BiPAP, or with mechanical ventilation, the intrapleural and intrathoracic pressures become positive due to the application of positive pressure throughout the entire chest. So how does spontaneous inspiration affect usual hemodynamics? So in a normal spontaneously breathing patient, as I mentioned, the diaphragm and the intercostal muscles contract. This leads to a more negative pleural pressure. I simply think of this negative pleural pressure as a suction in the pleural space. With more negative intrathoracic pressure, venous return increases. Essentially, there's less impedance to flow, and this increases preload to the right heart. This negative pressure or suction actually also acts on the pulmonary arteries and decreases systemic vascular resistance. This decreases RV afterload. LV afterload actually increases. So this has never been all that intuitive to me, but ultimately this negative pressure effect or suction effect decreases the LV pressure. This ultimately creates an absolute gradient that is increased between the left ventricle and the aorta. So your LV EDP is lowered, and that means that the absolute difference between your LV EDP and your aortic pressure is greater. And so in this way, the left ventricle has to work harder to pump against a similar aortic pressure. Let's contrast this with positive pressure ventilation. So positive pressure ventilation exerts its hemodynamic effects on principally through increases in the alveolar pressure and intrathoracic pressure. So with positive pressure ventilation, the airway pressure, the alveolar pressure, and then the intrapleural pressure all become positive. And that's what's shown here with all of these big plus signs. This ultimately decreases venous return. You can think of this either as exerting a positive transmural pressure on the vena cava or physically impeding flow to the right heart. Either way, this results in decreased venous return and decreased preload to the heart. RV afterload increases. So positive pressure ventilation compresses the pulmonary vasculature. This increases the pulmonary vascular resistance and then increases RV afterload. With positive pressure ventilation, the left ventricular afterload is decreased. Again, not entirely intuitive. However, I think you can think of this in two ways. So the positive pressure provides a buttressing effect essentially on the left ventricle. So this means it's giving a little bit of positive support to the LV. That means that it's easier for the left ventricle to pump into the aorta, and your afterload is effectively decreased. The real reason for this is the baroreceptor reflex. So with positive pressure, the aortic pressure is transiently increased. This leads to baroreceptor activation, which then leads to reflex vasodilation and a decrease in systemic vascular resistance. So positive pressure ventilation is advantageous for the left ventricle in that it decreases LV afterload. So taken together, you can see that positive pressure ventilation may have beneficial effects on cardiovascular hemodynamics in some situations, whereas in other situations it can be harmful. So I think positive pressure ventilation and PEEP are frequently vilified by cardiologists. I would argue that this is a pretty myopic view and that the effect of positive pressure needs to be examined with respect to the patient's underlying pathology. In patients who are preload sensitive, positive pressure may be deleterious due to the decrease in venous return and the increase in RV afterload. So I think this means that you should be cautious of using PEEP or increasing the amount of PEEP that you're administering in a patient with severe RV dysfunction. However, for a patient with severe mitral regurgitation and a dilated left ventricle, positive pressure decreases the LV afterload, which is advantageous for their MR. It also then has this buttressing effect on the LV, and the LV diameter in patients receiving positive pressure ventilation is actually decreased. This ultimately can lead to a decrease in mitral regurgitation. Additionally, in patients who have RV volume or pressure overload, you may have septal shift into the left ventricle. This can decrease the preload in the setting of positive pressure ventilation. So you end up ultimately with a shift of the LV or the septum into the LV. When you apply positive pressure in this situation, the decrease in preload may actually optimize the LV filling, and you may see an increase in your cardiac output. So I think these are just some of the many ways that knowledge of mechanical ventilation and the effect of mechanical ventilation on hemodynamics will lead you to have improved care for your patients in the cardiac ICU. Whew, that's a whirlwind. I'm going to 10 minutes on vasopressors. How about that? We ready?
Yeah.
Okay. All right. So we've seen charts like this since medical school pharmacology. I personally find this to be fairly overwhelming. So I was going to go through this, and let's take a look at each of these drugs one by one in like 30 seconds each. So norepinephrine. Norepinephrine is a potent vasodilator. It is a reliable vasodilator. It is equivalent to epinephrine and phenylephrine in its ability to augment the systemic vascular resistance. Norepinephrine is unique in that it increases MAP, but does not significantly increase heart rate. This is in contrast to dopamine and epinephrine, both of which increase heart rate. Theoretically, this is advantageous because you'll have less myocardial oxygen consumption with norepinephrine than with epinephrine or dopamine. With norepinephrine, you may have a slight increase in cardiac output due to beta-1 activity. And notably, norepinephrine has no beta-2 activity, and so lactate does not increase. We'll talk about that in a moment. So norepinephrine. Epinephrine is promiscuous. It binds to alpha-1, beta-1, and beta-2 receptors. However, there's a low dose and a high dose of epinephrine. Low dose is normally just 1 to 2, by some people saying maybe 1 to 4 micrograms per minute. In this situation, it increases cardiac output, and it actually can decrease SVR. This is basically due to you have alpha-induced vasoconstriction that's offset by beta-2 receptor activation. So beta-2 causes vasodilation, alpha causes vasoconstriction. These two sort of negate themselves. So at low doses of epinephrine, your SVR effect is not that impressive, but because of the beta 1 stimulation, you get increased cardiac output. High dose, however, really, I typed that wrong, I'm so sorry. It increases your cardiac output and it increases your systemic vascular resistance. So all doses here increase your heart rate and they all increase your myocardial oxygen demand. The beta 2 stimulation also leads to secretion of or elevation of lactate levels, which in a patient where you're already concerned about shock and you're using lactate as a marker of end organ hypoperfusion, confounding that with the administration of epinephrine can be problematic. 2 comments on all of this. During my interventional fellowship, I had a staff appointment in our cardiothoracic anesthesia department, and I worked in our mechanical circulatory support ICUs. CT anesthesia loves epinephrine. They use epinephrine really as a inotrope. So most of our cardiothoracic surgery patients come out of the ICU on low dose epinephrine. Unfortunately, the nurses then just titrate it up. And so what I think that they're trying to use is this low dose epinephrine where you end up with the increase in cardiac output so that it's acting as a inotrope, but that the beta and the alpha kind of negate each other, so you don't have much of a change in the systemic vascular resistance. Unfortunately, I think when this gets started at the bedside, people just crank it up and you ultimately increase your SVR. And so you have a sick heart that's beating against a increased SVR, which in my mind isn't ideal. Also, there's a discussion about whether epinephrine or norepinephrine causes more arrhythmias. In the literature, there is no good evidence for this. Cardiologists in general, though, tend to think that norepinephrine causes less atrial and ventricular arrhythmias than epinephrine, but our CT anesthesia and surgery friends tend to disagree. So here at the clinic, the Cleveland Clinic, I'm sorry, Mayo would take offense to that, but we tend to, all of the cardiologists will, if they're concerned about atrial fibrillation, we still use norepinephrine. The CT anesthesia crew will always use epinephrine because they feel like it causes less atrial arrhythmias. Phenylephrine is a pure alpha agonist. It causes vasoconstriction with minimal inotropy or chronotropy. So your SVR will decrease almost always. This decreases your stroke volume. However, most studies will show that your cardiac output is largely maintained if your EF is normal because you increase your heart rate. And so obviously, I think the way that we see this frequently in our cardiac ICUs is that we administer phenylephrine for LV outflow tract obstruction so that we decrease our, LV outflow tract obstruction. The other place that we may use it is if we really are having lots of trouble with atrial arrhythmias, phenylephrine, since it's purely alpha agonism, may be a good pressor to choose. Dopamine is messy. It is one drug that can essentially function as 3 separate drugs based on its pharmacology. So it's a beta 1 adrenergic agonist, which can increase inotropy and chronotropy. There are 3 different dosing schemes for this. So at very, very low doses, 1 to 2 mics per kg per minute, you predominantly get this dopamine 1 receptor activity, and this increases renal, mesenteric, cerebral, and coronary vasodilation. And so I think this is where this sort of now outdated idea comes from, that you can have low dose dopamine to improve your renal perfusion. That's true if I guess you put on just 1 to 2 mics of dopamine, but unfortunately in practice you put it on and it gets titrated by the bedside nurse, and then you're in one of these other ranges where 5 to 10, the intermediate range here is truly variable. In patients, we don't know. Is it going to, you're stimulating beta and you're stimulating dopamine receptors, and it's hard to tell what its effect's going to be. At high doses, dopamine has a predominant alpha effect. It acts more like phenylephrine, and so it increases your SVR. So I think that it's just messy, and that most people don't really understand the differential effects, receptor effects based on the dosing. And so I think that if you put on one drug at the beginning of the day and you don't have very strict parameters for titration, that you may end up coming back to a patient that's on a very different dose with a very different effect. Vasopressin is antidiuretic hormone. This binds to the vasopressin 1 and 2 receptors. It causes smooth muscle constriction. So in septic shock, ADH is obviously a naturally occurring hormone. And in septic shock, it increases in the first 72 hours or so of septic shock, but then it becomes depleted. So the thought, when you think of vasopressin, what you should be thinking about is that this is really just repleting the depleted store of the body's natural vasopressin. And that's why we don't titrate it. We just give a steady dose and to replete what is decreased. So vasopressin increases SVR. It increases your mean arterial pressure. It has no catecholamine effect at all, so it has no effect on heart rate. One of the unique things about vasopressin is that it causes no significant increase in pulmonary vascular resistance. There's just not many vasopressin, I don't know if there are any, but vasopressin receptors on the pulmonary vascular bed. And so that means that in patients with pulmonary hypertension, vasopressin may be a very good drug to use because you end up getting increase in systemic vascular resistance, but you don't end up having any increase in your pulmonary vascular resistance. This is normally dosed at just 0.1 to 0.6 units per minute. If you go above 0.06 units per minute, you can induce skin ischemia. And clinical experience, just for if you're using vasopressin, is that hypotension is common following the withdrawal of vasopressin. You've suppressed the secretion of it also by the body by giving it exogenously. And so the recommendation is that you taper this 0.1 units every 30 to 60 minutes. Okay, I'm going to fly through this in 3 minutes. As most of you are familiar with, norepinephrine is currently the first-line pressor used for septic shock and cardiogenic shock in most institutions in the world. So I'm going to quickly go through how does norepinephrine defeat all of its other vasopressor opponents. And there are, this is a study from 2008 published in Intensive Care Medicine where they compared epinephrine and norepinephrine in critically ill patients. Similar findings have been replicated in multiple other studies, and practice patterns have evolved from these studies. But in this study, the one from 2008, that's the largest, 280 patients, it was all-cause shock, so anyone who needed a vasopressor. And they used a primary endpoint of an achievement of their MAP goal for greater than 24 hours without vasopressors. So how quickly did they get these patients healthier and off of vasopressors was actually what they were looking at. The conclusion was that there was no difference in the achievement of their MAP goal between epinephrine and norepinephrine. However, they saw higher rates of tachycardia and elevated lactates in the epinephrine group. And this ultimately made the physicians uncomfortable. So the epinephrine group had a much higher withdrawal of patients from the study due to the tachycardia and the lactate. So it may be similar in efficacy, but some of the untoward side effects of epinephrine have made it less desirable. So after this study, and I think a couple of the other smaller studies, epinephrine fell as a second-line choice to norepinephrine. Quickly, SOAP2 trial comes out in 2010, doesn't seem that long ago. At that time, both dopamine and norepinephrine were recommended as first-line vasopressor agents in the treatment of shock. And the SOAP2 trial ultimately sought to determine if one agent was superior to the other. This was a multi-center randomized trial of 1,700 patients. And let's see, you can see, so this enrolled all comers for shock, but cardiogenic shock accounted for 16 to 18% of these patients. The mortality rate in the dopamine group versus the norepinephrine group for all comers was not statistically significant. However, when you looked at the rates of arrhythmias, there was a statistically significant increase in the rates of atrial and ventricular arrhythmias for patients with dopamine. So not good for our cardiac patients. And then the kiss of death for dopamine was that the rate of death was significantly higher in the cardiogenic shock patients who were treated with dopamine than in the group treated with norepinephrine. So at this point, norepinephrine has conquered epinephrine, and it certainly is better than dopamine. It actually kills less people and causes less arrhythmias. So norepinephrine, drug of choice. That's what I just said. Rate of death is higher in cardiogenic shock patients treated with dopamine. Just going to finish with, what about cardiogenic shock? So unfortunately, data and trials regarding vasopressor use during cardiogenic shock are scarce. Most of what we know is extrapolated from subgroup analyses of larger undifferentiated shock trials, as I just showed you. There have been 2 Cochrane analyses that concluded there is insufficient evidence to prove superiority of any vasopressor in cardiogenic shock. There is 1 randomized control trial and 1 meta-analysis that suggests norepinephrine may be preferred over epinephrine. Notably, these Cochrane analyses, the 2 of them, they were published in 2016 and 2018, and that was before the publication of our 1 and only randomized control trial in this space. So this is it, the 1 randomized control trial for pressors in cardiogenic shock. This was published in JACC in 2018. Ultimately, this was a study of 57 patients, so take it for what it's worth. All of these patients had cardiogenic shock secondary to acute myocardial infarction, and the primary endpoint of the study was cardiac index evolution, which was essentially an assessment of cardiac index over the course of 72 hours. This ultimately showed a higher incidence of refractory shock in the epinephrine group, prompting early termination of the study. So you can see that, so you can see that here, the refractory shock group, certainly statistically significant higher rates with epinephrine than with norepinephrine. So this was stopped due to that, the rate of higher shock in the epi group. And here, this leaves us with norepinephrine, I think, being the pressor of choice for cardiogenic shock. So this is not supported by robust data, but my clinical opinion is that in cardiogenic shock, our first-line agent should be norepinephrine. The trial data that we have, although limited, shows that that has less signal for harm. All right, exhausted. So my hope would be that maybe this helps you in some way know how to safely and effectively manage your ICU patients. My only parting words here are, when in doubt, phone a friend. There are lots of critical care and anesthesia providers around who do this for a living. They love to talk about these things, and I'm sure they're willing to help if you just give them a phone call. So this is me. This is Cleveland in like the 1 month of the year that we have blue skies and no snow on the ground. So that's it. Anyone have any questions or anything I can answer?
Thank you, Dr. Gage, for really very enlightening, at times going back in history a little bit about ventilation, but you explained it so clearly, and it was very good. So thank you really for taking the time.
Thank you very much. I appreciate it, guys. Thanks for the opportunity. So
I'm pretty sure we have some questions.
Sometimes in January, I would like to come to Houston sometime. All right. I hope everybody
exchange program.
That sounds good. You come here, I'll go there. All right. So if there's no questions or anything, thank you.
I have a quick question.
Oh yeah.
I'm pretty sure there's somebody.
Nadeen.
Don't go too early.
An important question, since I'm going to be on ICU next week. How do we know somebody is ready to be weaned off the ventilator? What things do we look for, and what tests can we order to start the weaning process? Yeah.
So good question. I didn't get into it because it's a big discussion, but I think that the first thing you have to assess is safety. So you're looking at the ventilator settings and what is their FiO2. It needs to be compatible with, so the first thing that you do, I guess, is spontaneous breathing trials. So that means that you're using CPAP or pressure support ventilation. And ultimately what that is we turn, in either of those, you turn your FiO2 down to something that is similar to what they'll be breathing on room air. So, 40% at the highest, all the way down to 21% FiO2. You then provide them with just enough support to overcome the resistance in the tube. So normally that's like a pressure support of 5 and a PEEP of 5. So you'll hear us refer to CPAP of 40, 5, and 5. But so you put them on minimal ventilatory settings, and you make sure that they're awake enough to participate. You then monitor once you have lightened their sedation, and then see what their ventilation does on those minimal vent settings. You need to make sure that their respiratory rate is something that is sustainable. There's no hard and fast rule for that, but something that you think that will not fatigue them. And then some people in different ICUs have different practices. You do not have to get an ABG. Lots of our patients in our cardiac ICUs have ABGs, so we'll check an ABG after 30 minutes of being on pressure support or CPAP. And if that is, the ABG looks good and compatible with successful, like that's a ABG that would be successful without a ventilator, then I think that it's reasonable to consider extubation. In the MICU, where I train, for example, most of those patients don't have arterial lines. So in those situations, we really are just looking at their SpO2, make sure their SpO2 doesn't fall, make sure that the respiratory rate is compatible with something that doesn't fatigue them. And then the things to ask when you walk in the room from the bedside nurse and the respiratory therapist are, do they have a good cough? Do they have an air leak? And what are their secretions like? So those are things that you may not know as the provider walking in, but the respiratory therapist will check for a cuff leak if they know. This means that if there's a lot of edema around the endotracheal tube, then even when you deflate the balloon that's holding the ET tube in place, then that edema is hugged up against the tube, and so you don't hear air across the tube. So respiratory therapists can tell you about an air leak, they can tell you about their secretions, and they can tell you about the cough. The bedside nurse should be able to do that also. So those are the pieces of information you need from them. Your assessment, I ask everyone, I wake up, talk, look at me, and then I say, can you lift your head off the pillow? If they can do that, normally things are going to be good. If they're weak, they may not be able to lift their head off the pillow. And then I make them follow a few commands for me. So that means that I ask them to show me a specific number of fingers or right hand thumbs up, so that I know that they're understanding what I'm saying, and that if I ask them to breathe once they're extubated, there's maybe a shot that they're actually going to do it. So assessing physical strength, how cooperative they are, and then I always ask them how big, to say, okay, take in a big breath. And in depends on what your ventilator looks like, but there will be a tidal volume that's listed on the screen. And I want to see that tidal volume increases significantly. So normally people are breathing a tidal volume that's in the kind of 300 to 500 range. And I ask them to take a big breath. I want that to increase to 700, 800. If a patient can take a big tidal volume for me, and can follow commands, and then the nurses and the respiratory therapists say that they've met these other parameters and they do fine on 30 minutes of a spontaneous breathing trial, the tube comes out. And I think that the one thing to note is that when patients self-extubate themselves, they actually, less than 1 in 2 of those patients get reintubated, which means that as providers, we're leaving patients intubated way too long, right? And that we normally consider it successful or appropriate if 1 in 10 patients gets reintubated. That seems to be a reasonable thing for where we're not leaving too many patients on the ventilator too long. And that's a sort of where we're willing to accept reintubation. It inevitably will happen with some patients.
Thank you.
Of course.
Dr. Gage, you have one question here.
Yeah.
And a lot of kudos. Let's start with the question. Do you use RSBI, which is respiratory rate, I presume, divided by VT or tidal volume? I'm guessing, as part of your weaning criteria?
Yeah, I don't. In our MIC, I was never. So it's interesting because in medical school, so I guess this is my 9th year out, and in medical school, RISB was like a thing that we talked about all the time. I think it's an additional objective need that you can have. But it's ultimately looking at their respiratory rate and is it compatible with sustained breathing on their own? And then what are their tidal volumes and can they augment those tidal volumes? So I think that you certainly can look at it and figure it out. I haven't used it until I think it's under 150 is appropriate. But it's not something that I routinely use.
Okay, well, I can read amazing, thank you. Fantastic lecture. Excellent refresher, thank you.
Okay, I don't need all that. You guys are too kind.
The most important one for you, this was an amazing talk, exceedingly useful. I'll be using whatever you taught this weekend.
All right, if you have any questions, you can call me too. You all text me or call me. I'm happy all the time I love the ICU. And so even if anyone ever wants to talk about cardiac critical care, or God forbid you want to be a little crazy and do interventional cardiology and critical care too, just reach out. I'd love to chat with any of you guys.
Well, that's great. Say hi to all our friends at the Cleveland Clinic. And
I will, and you guys stay safe, okay? Right. Thank you so much. I appreciate it.
I appreciate your time. Thank you.
Thanks, Nadeen, for reaching out. Bye, guys.
See ya. Bye-bye.